Okay, we're going to talk about patient selection today. And this is quite a controversial subject, and I know there's going to be a lot of attacks on my right and my left, but I can handle it. Bring it on. And maybe you guys can agree or disagree, and please stop me and tell me. I have no financial. I wish I had financial relationships. My life would be great. And so it's not enough to do your best, but you have to know what you're doing. So you can do. You know, I hate to say this. I was telling my wife I was driving here. There is an enormous amount of lack of thinking in the world, and I didn't use the lack of thinking. I always use some other word. I don't want to use it now. Different kinds of ECMO that we all know about. And Venous. Why we're doing it? Here's what an ECMO situation looks like. I wish we could show this picture to families so they understand what the end result are going to be. This is a typical situation, not an exaggerated situation. And the different configurations, VA. One statement I'm going to make right now, controversial from this picture right here. And I know I'm going to hit from both sides. You decide to put the patient on ECMO. You want to do VV or VA, Joe?
Well, it depends on the problem.
Okay, but I'm sorry to tell you, Joe, I disagree already. You put somebody on ECMO, put them on VA, you have to go max, and then you can de-escalate as needed.
What?
Do not do a journal crop, Joe. No time for a journal crop.
No, you're not serious. You're not saying.
I'm that serious.
You're not saying to take a patient who has normal cardiac function.
Hypoxia kills your cardiac function.
Well, it'll eventually affect that function.
Hypoxia kills your cardiac function, Joe. I'm telling you, Joe, you're assuming everybody is those perfusion like you. That's not true. Put somebody on maximum therapy, and you can de-escalate if needed. Save the patient's life and then de-escalate.
Okay.
Don't go step up. Getting the OR to put VV and then switch to VA. You know what that leads to. I'm very that serious. In an emergency, and that's my cardiac surgeons who I will be watching this because I'm going to send the link. Some suggest you agree. I have gangsters behind me. Some serious gangsters behind me.
I can't. I don't know, Doc. I'm going to let you. I'm going to let you keep going, but I can't say that I agree with this, and I'll tell you why very quickly. I don't want to belabor the point too long, but had a patient. In fact, Patrick's case. It was Patrick and Nate, and she was a 7-month pregnant female who developed severe ARDS. She was grossly hypoxic. She was having cardiac failure, LV failure, secondary to the hypoxemia. And if you look at the various algorithms, the surgeon made the decision, because he was varying back and forth what he was going to do. He said, we're going to do section, get the baby out. I'm cannulating at the same time, and immediately put the patient on VV ECMO. And as soon as they got the patient on VV ECMO, baby out, actually she had severe preeclampsia, right? But she went into ARDS, pulmonary edema, various different things. She had a lot of problems, but they got the baby out, VV ECMO, and as soon as they oxygenated her, her LV function went back to normal with a 60-70% ejection fraction, completely normal, did just fine. And the right decision in that case was because a lot of times when you do VA, yes, you support the circulatory system, but your risk of differential hypoxemia, if you cannulate fem is so high, that's scary. So I just can't agree with you. I'm sorry, I don't agree.
It's okay not to agree, but I'll tell you one thing, doing a journal club in the middle of the night is not a good idea. And how old is this patient again?
She was, 27 years old.
That's the answer to my question. Thank you so much. Have a great day. But moving along.
Okay, back to the slides.
Okay, back to different ECMO configurations. And here's for Chris to ambulate ECMO patients. The patients that with the respiratory dysfunction, we'll put them on VV, and then Chris can walk them around, and they can get back in condition and get back to their lung transplant status. So what's our agenda today? Look at patient selection and what not to do, who not to touch. And there's a whole list from everywhere. I have a very short list. And what's our exit strategy? And that exit strategy came from one of our political leaders who's alive right now, but is not one of our current political leaders. It was not an ECMO exit strategy. It was a war exit strategy. And what you have to look at your institution before embarking on ECMO. Before anybody thinks of ECMO, what should you think about your hospital and your referring hospital and your relationship with that hospital. Patient selection and contraindication. Patient selection is, you have to realize ECMO is not a simple situation. And what it entails, what's going to happen. You have to look at the ethics of the situation, palliative care. And I'll tell you something, it says ethics and palliative care consultations, that sounds great. I think ethics and palliative care will help a lot. And right now, our heart failure program has been mandated to be enrolled in a heart failure program to get an ethics and a palliative care consult. But sometimes I learned some new word which I use all the time. There is no time for a journal club at 12 a.m. These guys are not going to be available. I think the family needs to know what's going to happen once you put the patient on ECMO, and what's going to go from there. At the time of the ECMO is very important, whether it's respiratory or cardiac. Letting the patient struggle on the vent and hypoxic and the heart struggle, beating the heart with 20 mics of epi, being hydrated with 20 mics of epi, 20 cc's of vaso. The other day, I got a call about a patient on 100 mics of epi. And I was like looking at, is this IV hydration fluids? And respiratory situation is, what's irreversible? The question is, are you vaping? Is irreversible? Now you have all these young people are vaping. Are you going to put them on ECMO or not? And now you're going to say, oh, they're vaping, they're doing it to themselves. Vaping is going to be like the smoking situation now. And maybe, are they transplant candidates or not? And one thing I'll tell you, I'm going to repeat this over and over. If you are not, don't have an exit strategy, do not go on ECMO, regardless of where you are. Heart, lung, or whatever the situation. If there's no exit strategy, there's no plan, putting somebody on ECMO is not the right thing to do. And this is the short end of it, to be honest with you. If you don't think, not everybody has to die with cannulas, not everybody has to die with a heparin drip running wide open on them. So, and that's what we mean by palliative care. I think you guys disagree or agree with what I'm saying?
I think you're right, but I think because there's no time for the journal club, that sometimes we put them on ECMO and let's see where the ECMO strategy is. You know what I mean? We say, we have to buy time, and then let's see if we can find an exit strategy in the next few days if one emerges. Not always does that happen, but certainly that happens to some extent.
I like that. And at that point, I would definitely say you have to get ethics and palliative care, doctor of family, and see what the exit strategy is.
Mm-hmm. So I think we end up talking. I need to use this. I think we end up talking about exit strategies after we're on ECMO. So I'm agreeing with you. Right. We put it in because we're trying to save the patient generally. But within, I would say, 3 to 4 days, all of us, the perfusionist and probably the other doctors involved as well, we know if this is going to work or not. And I bet you we predict 90% correctly. And then there's that 10% where that patient actually really does recover when nobody thinks they're going to. But I think it's in my opinion, I guess, I think we put it on and then we develop an exit strategy. But are you against that idea?
I'll tell you one thing.
You can leave it on.
One of my surgeons right now says something that's very good. If you evaluate a patient for heart failure, this patient is not going to get a VAD for multiple reasons. Yeah. It's going to decline. If this patient comes in the ER today crashing, what are we going to do? We have to let him go. Because we already decided this patient is not a candidate. MRB, he failed MRB already. You see, that I think those kind of patients, if you said no from now, don't get emotionally, you know what I'm saying? Right. And they say, okay, we have to put you on ECMO right now. There's a patient, again, I learned from smart people because I'm not that smart. Our lung transplant program director says if you're not compliant by your medication at home, you are pulmonary hypertension. You elect not to take your medication at home. You elect not to be compliant. You elect to get pregnant when you're told not to, and now you came crashing through the double doors. Mm-hmm. And now, because emotionally you are 20-something, we're going to put you on ECMO. And you already proved to yourself you're going to fail. And are we going to improve your quality of life? That's what I'm saying. Maybe that's a little harsh, but it is. You have to be honest and realistic about it.
Mm-hmm. And those are hard calls.
Absolutely.
Those are very hard calls to make. But you're absolutely right, because if we don't get a handle on this, and this is what I fear, is that we will spend our way out of a therapy that can actually help people. And that's what I'm concerned about.
Absolutely.
I mean, that's a great point because, you know, there are a lot of patients that, you know, we see in all these satellite supporting hospitals that the surgeons or the, you know, intensivists or the cardiologists or whoever are seeing these patients, they immediately want to put them on ECMO when they know the underlying diseases and conditions and the possible outcome that this ECMO is not going to save them. It's just going to buy them time for the latter.
Exactly.
And then if you get the amount of occurrences of these patients not doing well, then eventually, you know, like you were saying, Joe, that, you know, that's going to hurt us more than help us because for the patients that do really need it, you know, we're wasting these resources putting them on.
Absolutely.
Right. And so really ECMO would be for acute injury or acute disease that we think is
That just
recoverable.
Exactly.
Yeah, recoverable.
Something recoverable.
Yeah.
Or you have an exit. Like I went to a meeting in France, and there was a patient listed on the lung transplant list, but he had antibodies, and they were waiting and waiting and waiting. This guy, and I'll tell you, we think we're crazy. I mean, I was surprised in France. They put the guy on ECMO, and so he can take his daughter to the wedding. And he went to his daughter's wedding on a portable ECMO and danced with her, a portable ECMO.
Wow.
And about 2 months later, he was able to get his lung. So, I mean, again, that was extreme, but I'll tell you, that there was an exit, so there was a plan. He had high PRAs, and they need to work towards that.
Right. And you have to, like you said, you have to look at your patient. And is the patient a good candidate? Are they compliant? There's a lot of factors, but I think you can distill this down into essentially three categories. The first is you have a bridge. You put the patient on ECMO. You don't know anything about them. You're going to have a bridge to recovery. You're going to have a bridge to a VAD or some other long-term device, or you're going to have a bridge to decision. And when that decision gets made is where I think we have a very uncomfortable environment of we put this patient on ECMO and it is obvious that they are not survivable. But until they declare themselves, if the family doesn't say we want to withdraw care, if short of that happening, they have to declare themselves. Our job is to inhibit their declaration as long as possible. It's not to facilitate it.
Exactly.
So there's a very big, that I think is the issue. The transplants, there's a strategy, there's a plan. The person who comes in who's 35 years old and should be survivable, you're going to throw everything at the kitchen sink. But I've been fooled too. 75-year-old grandmom, I was sure was going to be gone before the turkey came out on Thanksgiving, and she walked out of the hospital.
But if you're 35 years old and you're declined for a transplant because you're not a compliant candidate, you're not taking care of yourself, you're not taking care of meds. I mean, you got my
Right.
point to say you are declaring yourself already.
Yes.
Yeah. So, I mean, and you're going to lose that organ. So put your ECMO, you're going to lose an organ, which is something not right.
And especially since they're in such short supply
Exactly. Absolutely.
on the transplant patients, yes.
One subject I'm very sensitive about because I've seen a lot of drama with it, anticoagulation. So if you cannot anticoagulate, you cannot go on ECMO, obviously. Right. I mean, that's a big situation.
Mm-hmm.
So really,
I've seen them do it.
Absolutely. And the results have been, we've all seen
we
holes
all-
are leaking. Every stick is leaking blood out, and it becomes a big drama.
Mm-hmm. And the LV is full of thrombus.
Exactly.
Well, there's a big trend about not anticoagulating. You've seen a lot of movement towards, the VVs are largely not anticoagulated, and now we're seeing VAs not anticoagulated, provided a flow above about 4.5 liters. But
and I agree
I
with
don't
you.
know how
and
I feel about a lot of those, but
I have a big lecture on that. I'll tell you, it depends on the flow, it depends on your patient. And people also don't understand one thing, which I don't want to divert on a different subject. If you're weaning off ECMO, you need to anticoagulate higher because you are Because people don't understand that. They think, oh, you have to wean everything off. No, you're weaning off means you have to get the blood thin enough so you're not clotting. They don't get it. What can I say, sir?
But what other people don't think about too is that the outside, the exterior surface of the cannula, not just simply the blood path of the ECMO circuit, but the outside of this cannula that's this long, and the other one's maybe a little shorter, but in the arterial circulation, it's higher flow. I get that. But on the venous side, the outside's not anticoagulated. It's going to clot.
Sir, I don't know what to tell you. There's a lot of, issues. Anyway, indications for ECMO and ARDS, and you can look at different indications. For me, I'm not that smart. I'll tell you, you have ARDS. You are a candidate for a lung transplant, and and there's a cause we can identify. We should go for it. And you don't have any contraindications, you should get an ECMO. There's no problem with that. And this one, Joe, VV, I agree with you 100% right there. Okay? As long as there's no cardiac compromise. For pneumonias, obviously, and it depends on the age. Aspirations, patients that go to the OR for unknown reason, they aspirate while being intubated. Alveolar proteinosis is a very bad disease, and you have to get a lung transplant. Okay. Extracorporeal system for thymus obstructing the lung. And now for me, thymus obstructing the lung, you need to have cameras in the groin before you start to induce the patient. Smoke inhalation, the whole vaping situation we're talking about. Pulmonary contusion, I'm not sure I agree with that much, because when you're going to anticoagulate, you're going to have a problem.
Yeah, if you have massive hemoptysis, you're
Exactly.
in trouble. I mean, pulmonary hemorrhage is really it's a contraindication.
Absolutely, because unless you're gonna go coil the pulmonary artery, then you really do not. You get what I'm saying?
Yeah.
Our friend would go through a stent in the pulmonary artery,
Yeah.
or coil it, and then you can forget about the lungs. Now, the one thing I'll tell you, people should not hesitate if you do lung transplants and putting people on ECMO if the lungs are not working pristine. You should not have any hesitation. Nobody dies from a run of ECMO for 24, 48 hours after lung transplants. I think I've seen patients survive so well now after a run of ECMO for 24, 48 hours.
Yeah.
And instead of beating them and beat them with the vents.
You want to know something that we do at our hospital? The perfusion bypass machine that the lung transplant patients are put on is a cardio help, routinely. And then if they need ECMO, they just stay on it.
For us as surgeons,
That's a tremendously expensive cardiopulmonary bypass
But let
machine.
me ask you,
That
your surgeons complain that they don't have sucker bypass? They don't have suckers?
They use a cell saver. They use a cell saver.
Our surgeons want to use this.
But the lung transplant surgeon puts every person on a cardio help as their cardiopulmonary bypass machine, and probably 10% or so of them end up just staying on it right out of the OR for what he just said.
Yeah.
It's a very expensive, probably
$13,500
about 50-fold the cost of a regular, but apparently
just for the.
But can I tell you, I really think that's money well spent, because you just got a lung transplant. I'm gonna put you on ECMO for a couple of days, help you survive that situation. I think it's worth spending.
the patients do well when that happens.
They do very well.
Yeah, but you don't have to spend $13,500 for the circuit.
No,
They're
no,
just
you don't
choosing
have
to
to.
use a more expensive iteration. I don't have a problem with the ECMO part of it. I have no issue with that. I just don't think it's necessary, And again, we start running into this same issue that we talked about. We're going to spend our way out of, you don't need a $13,500 ECMO circuit for you to exercise your patient. They can push a little if they move things, or somebody else can move the cart for them, or whatever, a small cart, a little trolley or something like that. It doesn't have to be the iteration that, because that cardio help, you could put it on the IV pole, but they make them already like that, and it's 13 times cheaper.
The best thing is get your patient strong enough to push the ECMO cart himself.
Yes.
So I'll tell you, people should not think, my point is, should not think that the lung transplant has failed if you're coming out of ECMO. You're just helping the lung. You're just buying some time. Tincture of time, we're talking about that.
Yeah, and avoiding whipping it.
Exactly.
And barotraumaing it, and giving it high O2, inspired O2 content, and all the things you're going to talk about.
Now for diaphragmatic hernia meconium aspiration for little kids, for sure. There's no question about that. And like Joe and I said, massive hemoptysis, forget about it.
We had that happen just the other night. Yeah, it looked like a fountain of sangria. It was bad. It was bad.
Stents asthmaticus, I'm not sure because maybe I'm a little cocky, but I'm sure I can break somebody's stents asthmaticus, put them on anesthesia. Isoflurane for induction breaks status. You just have to convince people to take the patient to the OR. And a lot of people don't think the OR is such a taboo. You don't want to go there. You have to intubate, take the patient to the OR, put them on isoflurane.
So we put a number of them on ECMO actually.
I didn't know you could do that. So isoflurane
Breaks is a huge bronchodilator. Huge bronchodilator.
Okay.
So you put them on isoflurane, they break their asthma, they're very happy. And I'm old, so I still use theophylline.
Okay, yeah. That is old.
Old school.
I didn't even think they made it.
That's wrong.
I have a chat question. How can you justify cost of cardio help for CPB support if ECMO is not needed? Good question. We'll discuss that in the discussion area.
That's you, John.
Yeah.
Dial the administrator and ask them.
Okay, we'll get you the number. Dial the administrator. Go ahead,
I
Doc.
like that. Now, ECMO for my biggest pet peeve, ECMO for cardiogenic shock. Post-cardiotomy ECMO, how successful is it, Joe?
For post-cardiotomy, it's very well. For post-cardio, you're talking about coming off pump, weaning from bypass. I would probably say the appropriate percentage survival prediction would be 10%.
I mean, I'll tell you, I have biases, and post-cardiotomy, if you cannot go on implant and survive and come out, the chances of you surviving if we put you on ECMO are next to zero. I mean, for me, the maximum support post-cardiotomy is an Impala support.
I don't know why you love Impella. I do not like Impella.
I know you don't, but that's why I'm pushing the button. I'm pushing the button for a reason.
I think Impella. No, see, you did that on purpose.
I know. I've told you that. Right?
Yeah.
But must be careful. I'll be careful what you're gonna say. That's because I'm there for you.
No, I'm going to be careful. I mean, certainly. I mean, I'm politically sensitive. I think it has I think it's a good device, and I think it has good utility in the proper circumstances. But like many other devices, the company has an interest in selling as many as they can, and they overmarket it, and it's overused. So I think in the appropriate setting, it's a good device, but it has limitations. Placement, insertion first of all.
So which
migration.
are we talking about?
It doesn't matter. It could be
it
the Impella, the CP. It could be
5.0.
The 5.0.
If you have the 5.0 put through a graft, you're good. Everything else is moving around. I agree with you. But now I'm going to pick up my other guys because you're a little biased. So do you think you need an Impala with an ECMO for myocardial drainage? I mean, what do you feel about that?
When we put a patient on ECMO who has cardiac, here.
I'm sorry.
Just leave it on.
Yeah, but then
That's what I keep telling you.
I think that when we put somebody on ECMO post cardiotomy because they've got LV failure, then the way we're cannulating and the direction that we're putting more stress on that ventricle because we're flowing retrograde up through the aorta, and so I think Impella helps in that sense because we're going to unload the ventricle, along with giving perfusion to the brain and everything else. And so I think they work well together.
I agree with you 100%. I think people don't underestimate the importance of drainage. The drainage helps with myocardial recovery. The heart is not distended, it's not swollen like we said before. I mean, it does help myocardial recovery. So it does really, they work. That I agree, they work very well together. So I mean,
I thought you were going to pick on me.
See, I let Joe decompensate, and I pushed Joe's button for a reason because I knew that's his button.
Okay.
Okay.
Yeah, it does bother me a little bit because I think that having a patient on VA ECMO, and if you have a concern about LV distension and LV wall tension and decreased coronary perfusion and all the things that are associated with that, then I think having either and Impella 2.5 just to vent the LV isn't a bad idea, but you can mostly accomplish it with a simple left atrial vent. Just do a septostomy. If you have the chest open, you can just put it in the right pulmonary vein. But if you're right superior pulmonary vein, but if you're already in the ICU, you can easily do an atrial septostomy and just drain the LA that way, and usually works pretty well.
I have to tell you, I'm a fan of the ECMO and Impella combo.
And that's not a bad idea. It's not bad. I have no problem with it. I don't, but I think VA ECMO. I think in most circumstances where you have frank LV dysfunction post cardiotomy, and they're really needing a lot of inotropic support and pressure support, VA ECMO is superior to Impella, I believe.
Well, if you need a lot of pressure support and you have IV failure, you need ECMO for sure. I do not believe that on the RP. I do not believe in that at all. RP takes so much to put it in, and people lose so much blood. And anyway, with the other items, so let's say you hit 25 years old, you did a hit of cocaine, heroin, and now you're full cardiac arrest. Your respiratory, you're intubated, and you're good. So airway secure in the first 2 minutes, but you're in full cardiac arrest. But you're very young. You're gonna put down ECMO or no? But you did cocaine, heroin hit.
Right. I would say we would probably put
I think
that
he's
person on
asking
ECMO.
you, should you?
Yeah. Should we?
In your opinion?
I think 25. That's a very philosophical question, almost. Really. I mean,
That's
at
a very
25 years
philosophical
old,
talk.
people make mistakes, and I think that we should try to save them. We had a young man come in who got stabbed in the chest with a very long blade. It went all the way through his pulmonary artery and out the back of the pulmonary artery and almost hit his spine. And that happened to him because he was, cheating on his wife, and he told the girlfriend that he was married and she had a knife.
And
So-
the girlfriend didn't know he was married.
Right.
So he's cheating on his wife, but the girlfriend is who he told he was married to that didn't know he was married.
And
So-
we know how violent women are.
But I
Clearly.
don't want to get. There's lots of details. I'd love to tell you what really happened. But the thing is, we we saved this guy, and he did not end up on ECMO. But we didn't just say, oh,
But
he
this
was
guy,
stupid.
somebody
We're not
stabbed him.
going
He
to
did not
do
do his
anything
own
for him.
stupidity, you know what I'm saying?
Yeah.
This guy's somebody stabbed him. For PE, for a massive PE, this lecture is turning into something else. Okay, massive PE, I agree 100%. Massive PE, put the patient on ECMO, go to the OR, do a thromboendarterectomy. I think it works very well. We have an amazing surgeon that he does an amazing job with underorgans. Really,
McGilvery?
He's my best friend, so I don't know. Yes.
Yeah, he's a
Maybe
good
correct.
guy.
He's an amazing guy. Not
Yeah, he
good guy,
is.
amazing guy. Okay, post-cardiotomy, we discussed that already. Now, heart transplant, and that I'll agree 100%. Because you have to do 2 steps. If the heart is not working, we have a philosophical discussion. Look, go to HEB. Not everybody's heart is going to work when you get a heart transplant. This person gets shot right now, their heart is not going to be the best. But I'll tell you the best thing is that you have to go to put the patient on ECMO and list the 1A status. So the nurse not put the patient on ECMO. Put the patient on ECMO after heart transplant and just forgetting about it, it's not going to recover. List the 1A status. The heart recovers, you're very lucky, then it's good and well enough. You list 1A status, you give the patient another chance. That would be my utility for ECMO in this situation. Okay? So you cannot go back to the shelf and say, let me use BiVAT, let me see what's in the garage. You cannot do that. So, peri-procedural support for high-risk percutaneous cardiac intervention, I agree with that. High-risk PCI with ECMO. What do you think?
High-risk PCI with ECMO, I think it's a great idea.
I think it's an
I think
amazing
it's-
idea.
Yeah, much better. Again, I think it's much easier to do and a lot less cumbersome than Impella. They advocate Impella for those cases, but I'm a big believer in using ECMO for it.
No, I've done that in multiple institutions. High-risk PCIs with
ECMO, yeah, makes sense.
Absolutely. And now here's the more indication, contraindications. We discussed disseminate malignancy, that's for sure. Immunosuppression issues. I mean, I'm not sure even what that means. If you have a bleed in your head, I'll tell you, neurosurgeon has been clearing patients right now with bleeds in their head. And I disagree with that 100%. Because what happens in veterinary, you're going to have to anticoagulate those patients.
Yeah, it doesn't make sense. I
Doesn't
agree.
make sense?
No.
And those patients develop a massive blow up in their head.
Yeah.
And they have to give a craniectomy and really prolonging the pain of the family and the patient. I'm actually more concerned about the pain of the patient. You have a bleed in your head, and now I'm going to put the ECMO and give you more heparin or Angiomax, whatever it is. So I'm surprised neurosurgery is clearing them, but I don't understand it, sir. But I'm not that smart. Remember that. So now there's a big movement for lung transplant, and it goes back and forth. Put the patients on ECMO, extubate them, make them walk around, make Chris get them stronger. Chris has to get them stronger and ready for lung transplant. So, what's your guys' thought about that? And now even the cannula has a nice little headband, tennis headband. It's so fancy, so the cannula doesn't fall out. And I'm sure you've seen the cannulas fall out.
No, we have not.
You have not seen the cannula fall out?
I have in all of my years, I have never seen accidental decannulation.
Unfortunately, I have. It looks like a snake.
I have too.
Yeah. Maybe
Have
we've
you?
done the same one. It falls off and the pump is going, so that thing is spraying all over.
Yeah.
Well,
and you try to
no.
get that hose under control.
Okay.
You push the nurse in the room, go get that hose.
I take that back. Okay, we did have that one case. Who was?
Well,
with me?
it was me, and it was not ECMO, but it
No,
was,
it was
on
me.
bypass.
It was at that hospital where that other guy who's no longer here was. Remember that
Was there-
22-year-old that
Yeah.
we had? That was not the same. We're talking about in the ICU, an unintended decannulation I have never seen.
I mean,
The
with
patient
Avalon,
can
that's
themselves
a
or
long
it just
cannula.
fell out.
So
No, it was the surgeon who put it in actually was the one who accidentally pulled it out.
Wow.
Yeah. But that surgeon isn't here anymore. I don't want to say anybody's name.
No.
But
So are you worried about walking those patients? The cannula is going to fall out.
Well, I would hope that it's well secured. I mean, we do, external, the bands and all that, but I would also hope that it's stitched well. And sometimes they reinforce those stitches just for safety.
And I think
We
that's a problem when
we
it's not
mobilize
stitched
everybody.
in.
Yes, then it's
Even
that's
some
a,
femoral
it can become
views.
a
problematic.
huge
But
safety
not
issue.
femoral artery, I don't think. I haven't seen that.
Femoral views.
so there's a question for you,
Yes, sir.
Dr. Samir.
Yes, a controversial question, I hope.
Brian Crawford says, how do you take exit strategy, in quotes, into account when the receiving facility is 45 to 60 miles away and not on site to evaluate the situation? We have to ship all of their ECMO patients to them because of a lack of their resources. They don't have the resources to keep the patient.
Actually, I was going to come to that slide, but Brian, I'll answer that question right now. You have to prepare from the beginning. You have to have a good relationship with that receiving facility and discuss the criteria together and have a plan together. You cannot just be calling them out of the blue. I push put a neck right now. These are long-term relationships that have to be established. I have multiple lives. In my other life, I have to call Penn and send them patients to a small hospital. And I know Penn's criteria. And before I decide to do something like that, I will make sure that Penn is going to take that patient, not call them, tell them, you're going to take that patient. Long established relationships and meetings together and CMPIs together and case reviews together. And you have to have a good collaboration with that hospital. It sounds so like warm and fuzzy. It's not really. You have to just see those guys and talk to them all the time and see what their criteria are. So I think you have to know what your receiving facility is going to send when you get to that. And that's a very important thing before you think of putting an ECMO someone. So more contraindications on ECMO. One thing, I see the contraindication to any, I'll tell you, unwitnessed cardiac arrest. I don't call anybody for unwitnessed cardiac arrest, something like that. Unwitnessed cardiac arrest, we have to accept death sometimes. Like one of my cardiologists, a good friend, he says asystole is a sign of death. We need to accept it sometimes. So now one big subject which a lot of people don't understand, ECMO or Impala or whatever, with aortic regurgitation, that you're just making a nice good circle. The circle is going around and around and around and going back. People don't understand that. AI is a very bad thing. Whether you have a balloon pump, whether you have Impala, whether you have ECMO, whatever, you have AI is a really bad thing. Mm-hmm. A lot of people don't get that, don't know why. Now, another question here. Do you think you should put patient on nitric oxide if you have a patient on ECMO? And I'm not DV, I'm going with AV. You have BIV support now. Do you think you should put patient on nitric oxide? I'm asking that question.
Yeah, you're asking. I mean, let me think.
Think, boss.
No, I would probably say if they have pulmonary hypertension and you've probably already tried the nitric oxide before you made the decision that failed that already, then in that case, I would probably say, you're going to mechanically relieve their RV obstruction. So I'd probably say no.
To be honest with you, for the reason you just said, I feel like I'm going to relieve the RV obstruction by putting on nitric oxide. I'm giving this patient the best chance to come off.
So you would say leave it on?
Leave it on.
Okay.
Yeah. Leave it for the best chance to come off. A lot of people don't want to do that because of the money part, not because of anything else. Mm-hmm. I think you need to leave it on, for giving them the best chance to come off.
So leaving it on because they were already on it before you put them on ECMO.
No, I want to get the pressure off the right heart as much as I can to have them come off later. Because it's all about I believe in my cardiac conditioning. You get the heart used to get the obstruction in front of it off, and I think you'll be okay. You know what I'm saying? So I would like you to be okay that you have a better chance of coming off, than just staying on ECMO.
Yeah.
So I want to give you the best chance of coming off. So that's for me. I think nitric should be misted in the air. I would love to inhale some nitric in my house.
I agree with that. Unfortunately, at some of the places we serve,
they don't have nitric oxide.
It's
Right.
available.
So that's right, exactly right. So how do you feel about cooling your VA ECMO? So let's say you have a cardiac event, could be a PE, could be whatever. You have some kind of witness arrest. You've done CPR, so you've got ECPR. Do you automatically go to therapeutic hypothermia protocol and drop their temperature down 32, 34, whatever it may be? Or do you want to keep them normothermic as long as the circulation is being supported?
No, I believe in hypothermia, but not 32, 34.
34, you'd stick with 34?
Moderate hypothermia. Mm-hmm. Okay, because severe hypothermia, I really worry about bleeding a lot. The metabolic deranges.
Yeah, cold blood don't clot, that's true.
Metabolic deranges are really bad for you when you get that cold. And there hasn't been much benefit shown between 32 and 34. Mm-hmm. And obviously it has to, like you said, witnessed. If it's unwitnessed, no, that you're done. You're unwitnessed, you're dead. I'm sorry. I know it sounds harsh, but it's that. You know what I'm saying? So you really have to think about that. And again, anybody, what's your cutoff for age? You guys have a cutoff for age for ECMO?
We do not, but
No,
I
we
have
do.
seen people in their 80s, recover,
No,
right?
we have a cutoff. We have a cutoff age.
What's that?
I think it's 75.
Well, we haven't followed that. I know we.
No, but we have it. It
Okay.
is we do have it. There is a protocol, and I do believe it's 75.
And I believe that protocol is there because we do have the same. But to be honest with you, I'm not too much concerned about the cutoff age, except about your situation.
Yes.
What's happening and what your exit is. If you are 80 and you aspirated in the OR because some guy made you aspirate when he's trying to intubate you, and then I'm okay with you going on ECMO for a short period of time to get you over that hypoxemia part. So I'm not beating your lung up with peak airway pressures of 60 and things like that. Or you're gonna give him like a lung lavage to see what's gonna happen.
Yes. Yeah.
So if you have, I don't care how old you are, as long as there's something I know I can get around, we're gonna get done with it.
Right.
Yeah.
Right.
Well, I don't think you can go with an absolute age. I think you have to look at
the
the
circumstances.
relative age. Right. You have to look at the body habits of the
and there are
person.
other
and the-
comorbidities.
all
And
that
you're in the
stuff.
cath lab, somebody dissected your LAD, and now I'd rather put you on ECMO, get you to the OR, fix that LAD, and hopefully you can survive. There's a good, if you're not downtown, you might survive. You know what I'm saying?
Yeah.
So,
Look, I've seen 82-year-olds that are still got a lot of life left in them. They're out playing golf every day. I don't think you can go, or 78-year-old. You can't go by a relative. You can't go by an absolute age. But I think it's there for a reason. It certainly it's a way for you to say, look at the patient and go, oh my God, this person is just so frail and looks grossly decompensated and they're 76. Okay, we don't have to do anything. I think it's a lot of these protocols are there for the
because there was nothing else, Joe. They
legal
had to put
protection
something,
than anything else. Yeah, sometimes.
To be honest with you, was a patient 2 years ago. He was 85 years old, and when we went to MRB for his VAD, he wrote a statement that all what he wanted to go to his son's bar mitzvah. Also, what he wanted out of life. Okay, and this guy, when he sees me in the hospital, now gives me a hug every time. That he went through that. He's still alive. Not that he's going to live much longer, but he's getting a little older. But again, he achieved the goal that he wanted. Is that something which, economically? But I'll tell you, that was, for this person, that was his goal in life. So you have him achieve something that he really wanted out of life. For me, that gives me satisfaction.
Right. Yeah.
That's like the French people when the daughter had her dad dance with her, and in France they don't spend money like we spend. You know what I'm saying? And I was very surprised that in France they did that. So
They have the ambulance with the ECMO. Are you
Right.
kidding me?
Yeah,
they
they do.
are spending the money. But
okay,
speaking of France, I don't know if you saw this or not, but they had that big sale, the gun show of all of those French war rifles. They were selling them by the crates. They were never fired, only dropped once.
I'm telling you, I keep asking my wife to buy me a drone with a Hellraiser missile, and she doesn't want me to buy one.
I'm
All
kidding.
they want
I
is a
have a
drone with a
drone.
Hellraiser
I
missile.
have a drone back there with a mini Hellcat missile on it.
See,
Yeah.
he has one. I want one.
We have one. I'm gonna let you fly it today.
That sounds great.
I know exactly where you can take it.
I know to where I can take it to.
I know exactly whose house you're taking it to. Okay.
So I'll tell
Exit
you.
strategy.
So I'll tell you, really. I'm sorry. I went back at one.
Go back. Okay, sorry.
I'm sorry, sir. I got distracted. So here's the punchline. If there's no exit strategy, then there's no exit. Now, we talk about the question before about the hospital resources, and that are it's a very important question. Your blood bank has to be alert and oriented. I know, and I'm not here. Some other facility, the facility is located in one hospital in one state. For me to get platelets, I would have to get from another state. So if somebody needs a lot of platelets, I have to transfer them out. And this is not a unique situation. This situation exists all over the country. So we need to understand that. We're spoiled here. You need to have good perfusionists, good CV surgeons, good vascular surgeon for distal limb perfusion. So do you guys believe everybody who gets fem echo needs
Yes.
a catheter? You agree?
They all get DPC, yes.
Exactly.
And a vascular surgeon is called a lot of times, not for that, but for repairs of femoral artery
Exactly.
simulations and difficulties later.
Exactly. You need to have 24/7 intensivists. You need to have good pulmonologists, hematologists. One of the biggest issues with ECMO's anticoagulation is a big controversial subject. I know we're going to have a lecture about it at some point. And really, a good hematologist is needed to help you. You need an interventional cardiologist who can perforate the septum, like Joe said before. Heart failure cardiologist to put the patient, list the patient. ECMO trained and certified nurses. Good PharmDs to adjust the drugs for these patients. It's very important. And if you don't have any of that, you need the ECMO telemedicine support, which is a new happening movement for hospitals that do not have this kind of backup support. And ECMO telemedicine actually can help you a lot. You put a patient on ECMO in your hospital, ECMO telemedicine person will have a relationship with the other hospital to you transfer to. They will know their criteria. It will help you in placing the patient wherever we want to put the patient for wherever they're going to get a heart or lung transplant. So I think that's a big thing that's coming up and happening. So I'll tell you, you have to have these things in place before you decide to embark on ECMO. ECMO is a very expensive, endeavor. Here's a digital technology tele-ECMO. For all this equipment, you need to just have 2 laptops to take care of that patient. How about that? And know where to put with them.
So
Tell me, sir.
this is somebody that is running their ECMO from home. Is that what you're saying? Through their
No, they're not. They are. See, the big word is running. How about monitoring?
okay,
Managing.
Managing.
So here, so mean, and I don't make it, I want to simplify it and don't throw the mic at me, or you can, it's okay. So ECMO really, what's the parameters we can change in ECMO? The flow, FiO2,
Right.
okay,
Sweet.
and the volume, and the anticoagulation. Anything urgent surgical intervention cannot really happen at the bedside, or it can happen at the bedside, but the surgeons are not always available. So that tele-ECMO person, I'll tell you what he should do. Have good relationship with the nurse. The nurse calls him and says, "Oh, I have this kind of happening with the flow. This was happening with my gas, and then we'll have to manage the situation. This is what's happening with my anticoagulation.
Right.
They have to manage that. Patient needs to go to the OR. That ECMO, the tele-ECMO person should be able to call the surgeon. Tell him, you need to take your patient back to the OR. That's happening, and then call the perfusion service. And this patient needs to go back.
Well, that's interesting. That's something we've
Yeah,
been talking
talk
about
about
around
It
here.
is.
So
It is.
yeah.
Let me ask you this, Patrick, and Dr. Samir, and you probably will know as well, Christine. John, you do a lot of ECMO. Min, in the community hospital that is not an ECMO center where you have 12 ECMOs going on all of the time. You have the one here, one there ECMO. What is the single greatest cost associated with delivering ECMO to that patient?
Perfusion. It's one of the
Person
top.
standing at the
It's
bedside.
one of the top ones, if not the top one. Yeah,
Yeah.
It is unfortunately, this is the top one.
it is the top one.
This is the top
And
one.
that's why
So-
we discuss this from a healthcare professional's perspective, even though I'm also a business person and we all work to make money, right? None of us work for free. I mean, that's just life. We shouldn't. But there is a definite problem. And that is there are multiple hospitals that do not want to even offer ECMO as an option because it will essentially break their bank. That's not good for patients. So our first responsibility, in my view, is to patients that are in need, whether they're ours or anybody's. It doesn't matter who it is. That's why we share information. That's why we do these lectures. We have these discussions. And that's what we do. And we do that because we're here to all help each other do the best we can for any one patient, whomever that may be. If we don't find a solution to having a perfusionist standing at the bedside, sitting at the bedside by the ECMO pump 24/7, then patients are going to fall through the cracks. Hospitals will stop providing ECMO service because it's too expensive, or hospitals that should have an ECMO option and a relationship with another facility who could receive them, whatever, not to keep them, but they won't do it either. We have to make ECMO more like what balloon pumps are now today. What they used to be, perfusionists were there at the bedside, inflating and deflating with the millisecond delay from
Minute
the
to
R
minute.
wave and the P wave. All of that stuff. CRRT machines were at one time, oh my God, you have to have some specialist do this. Now nurses at the bedside do that. ECMO has got to become that type of a therapy if the therapy is going to be utilitarian to more patients that need it. So that's my philosophical thought.
Well, what happens the center that I'm at, and you came down there, Joe, we have a very large
Much
ECMO
more
center.
efficient.
The head cardiac ECMO surgeon has networked himself through dozens and dozens of hospitals, all in our state and out of our state, where he's networked himself and endeared himself, I think, to the cardiac surgeons there at those hospitals who are willing to put an ECMO patient on, but they are not, with all the list of the specialists you listed there, and the undertaking that it is involved, are not willing to say, I'm going to put this patient on ECMO, and now what are we going to do? Well, what are we going to do is we're going to come and get them. Our facility will come and get them. Or we'll go there and cannulate them, or we'll pick them up, either way, and cannulate them at our facility. the phone calls are made right away from that cardiac surgeon to our cardiac surgeon. This is what I have. What can we do? Can you take the patient? Do you want us to put him on? Do you want to come get him? And everything's coordinated, and we do it very quickly. We do it all every day, so it's very efficient. But he's established a network where all of these centers, small centers, are willing now to put a patient on. And they know we're going to come and get him that day or the next day. And they've made what money they can from the insertion, which is significant. But the long-term cost of having that patient there and not survive, they don't have that. And it's shown that the survivability and the mortality and morbidity is much less when much less when a patient comes to an experienced center.
Survival is higher volume,
right.
higher survival.
The mortality.
That's common.
Yeah, so
in everything.
So that has been a solution that I've seen. But the thing that some hospitals make a mistake is they read this thing, well, ECMO buys people time so they can heal, recover from whatever. So some can. So they take that and they set it and forget it. If you do that with ECMO, you will never be successful. Correct. It involves a 24/7 intensive, eyes on, hands on, every minute of every day with multiple specialties looking at what the trends are.
And what you're talking about, which goes against the economic philosophy of this country, including in medicine, is centralization of services. That's what you're talking about. But we don't have that. Not every community has a hospital like yours that goes and takes all these patients. And then what about the patient who's just a little further away that's in a community hospital that does 400 hearts a year, that should have a heart surgery, an ECMO program, but doesn't? I know two right now, not far from where we are right here, that do not have the ability to provide ECMO, that are doing between 300 and 400 hearts per year and have patients who end up getting put on either balloon pump or maybe an Impella, and they don't survive that part of it. They needed more and they just didn't make it, but could have. So the other problem is your in, if you just keep moving that ring out, your in can be full. You can have a no vacancy sign. You just got to keep building. I understand that, but it takes a process. You got to fill all the beds and be at capacity for a certain period of time before anybody's willing to now spend another couple of $1 billion to build yet another wing to your facility. And this is just a big problem. So centralization of services, I think, is really good in terms of improving survival through volume experience, and of course having all those other ancillary services. At the same time, not having the ability to take that model and put it over here in these other community hospitals means that you can't still manage all of the patients that need to be managed.
Well, what's happened is you start off with a community hospital that just puts them on and we come and get them that day. Then it happens over time that they stay there a day or two before the arrangements can be made. And now they've had to experience the patient 2 or 3 days. Eventually they have more and more and more experience. We have a hospital like that now that has gone from 1 ECMO machine, 1 cardio help, to 3. They do all their VVs and they keep them.
I wish you'd stop marketing for that company, okay? ECMO, just say ECMO pump.
And they send us all their VAs. So if you establish hospitals in your area that are willing to launch an ECMO insertion come and get program, they will eventually grow to be more and more of that. It'll take time. And then you'll have more business at those places where they're going to say, this VV, we did this for 2-3 days. It wasn't as bad as we think. Maybe we can hold on to it 4 or 5 days and see what happens. And then they had one do well. And now we have a hospital not far from us. 100% of their ECMOs have all been successful. All their VVs, they've all survived. Now they figure they could have 2 or 3 going. So I think. But if you never launch the insertion,
do they use perfusionist at bedside or nurse ECMO
perfusionist 24 hours? Yeah, now
24/7.
They're so difficult to go beyond perfusionists. You have to have a busy center. You have to train ECMO specialists. They have to maintain their training. There's a turnover.
Unless
it's hard.
You have somebody like Dr. Samir who's monitoring the patient for you via telemedicine, because now he can watch 4, 6, 8 in various different locations and maximize that efficiency like you do at your facility, one perfusionist and you've got 8, 10, 12 ECMOs going at the same time. So it becomes cost effective.
So maybe we should open Dr. Samir's call center. You know,
I think we need
and he'd
it.
just be there with operators answering
Now,
the phone
I'm
24
gonna-
hours a day.
now,
You know, that's my little call center, and because I mean I do tele-ICU, and I'll tell you, critical care experts are not that easy to come by.
Yeah.
So critical care have to go by that way, and I think it's working very well for us. You can have a very fancy center with the it looks like a space center, but that's not cost effective. Or you can have a simple setup. We have a camera. I can see, look at the room, see what's going on, and talk to the patient, the nurse, and the family. And it's very.
If you're talking to the patient, they don't need to be on ECMO.
Can I be controversial now?
Yes, we've been waiting for you.
Yes. Well, I'm going to be very honest with you. If I have to walk somebody who is on ECMO, I want the perfusionist right next to me. I do not want a perfusionist sitting in a computer 1,000 miles away. How do you feel about that?
Well, what's the perfusion going to stand next to you? Hold you? See,
No, but if there's an emergency, I am a physical therapist. I'm not trained to work that machine.
What's the emergency in ECMO that you're going to need a perfusionist in?
Well, if anything, if problems with the flow or problems with who is going to be adjusting the machine?
The nurse.
Okay, maybe a nurse, because I wouldn't be doing that. I'm not trained for that.
The nurse. It's not that complicated, but the thing is, Christine, catastrophic events that occur, massive air embolism, circuit disconnection, inadvertent acute decannulation, we can't help you. We can go get a tag and put it on the toe, but that's about all we can do. There's not much we can do. It's over. The ball game is over. 9th inning, 3rd out, done. Okay, we have managed all day to stay on time.
Except now, because it's my fault.
You have derailed us, so
I'm sure.
That's it. We need to focus on your talk and let's drill down.
Okay, so again, I mean, so this is how, I'm not sure, is this going to play? It might play. Is this a live demo how we're managing our
Can you play that video?
I don't know if does it play from here? Does it play?
No, they'll play it up there.
Okay.
They got it. There.
So this is a live call. Are we all okay?
Yeah, turn this sound down.
Are we all okay? Are we okay? Okay, I would give him a liter of LR now, okay? A liter of LR. Okay, please, yeah. So the input is coming in my headphones. Okay, thank you. So we're gonna be giving him a lot of boluses tonight, okay? Whenever his pressure drops like that, give him a liter, okay? Open belly with pus in the belly, and he was coming in. Let me know his hemoglobin less than 8, okay? Over his belly, and so he's basically hemoglobin less than 8. Okay, thank you. That's something we're talking about, hemoglobin transfusion.
And what you should have said was, and Christine, if the cannula comes out, put it back in.
So I mean, really, so you're able to talk to a nurse, assess the patient, and manage from there. I put all my orders. I have Cerna computer, another computer, and that's it. Thank you all.
You got us back on time.
See,
That was your last slide.
Yes.
Can I address what Christine, is that what
Yes,
she was
Chris.
just saying about?
You can call me Chris, that's fine.
Okay, your point is well taken, actually, because I say this all the time, it runs well until it doesn't.
Exactly.
It runs for days and hours and days and even weeks at a time, sometimes with very little hiccup, and then all of a sudden something's happening and somebody who really knows what is happening needs to be there and needs to say, we need to do such and such. And a lot of times that's a CCM, sometimes that's perfusionist, but it's usually somebody who's perfusion related when it comes to circuit hiccups and volume, different things like that. So unless you have someone who's working with perfusion almost day in and day out, who's not a perfusionist, it's going to take a very long time for them to diagnose even the simplest hiccups with the machine alarming, all kinds of pressure alarms and different things that it's saying what's important, what's not, and what to do about it. And if you do the wrong thing, it can go downhill, that much faster. And walking a patient is a scary proposition, even though it becomes routine sometimes. It's a pretty scary proposition if something goes wrong, because it's going to be very ugly very fast.
Yes, I mean, if something catastrophic occurs, there's nothing
even
can
the
do.
patient falling, like
Even the surgeon standing right there can't save.
But I'm going to turn the tables around on Christine now. You remember when we started your walking program in where we work, and there were objections on the program that people are going to extubate, and we're going to log roll them when they fall down and intubate them on the floor. Remember all these discussions that were had in meetings we had that I wanted to kill myself listening to that. And how many patients that you have walked have self-extubated?
None.
Thank you very much. Have a great day.
Handheld, massive.
Yeah.
Okay.
They do a good job of suturing and securing in. However, if you have someone for weeks or months, the tissue where the sutures are erodes, and it can become a bigger problem. Although I still have never seen one walking come out, but I have seen cannulas come out when we were turning the patient.
Turning the patient.
That I've seen.
But I'll tell you, John, my issue is when Chris is walking a patient and she has her help with her, they're paying attention to the patient. They're all focused on one thing, is that patient. She's her only focus on one patient. And the drama we had to go through to approve Christine's project, that was her project. To walk patients was, we're going to log roll people, we have to have the airway card. I've never had to intubate anybody on the floor that she has self-extubated. So all this drama, people are self-extubating on the bed. How many people self-extubate on the bed? 1 million. Why? Because nobody's paying attention. They're trashing around, nobody's paying attention.
I'll tell you something funny I heard about cannulation and decannulation just the other day. A surgeon said something. We had a scare where somebody we thought was going to decannulate from the neck. They were, on what was it? It was a Avalon, yeah. And he said, if there's skin on the cannula, it's the nurse's fault. If there's no skin on the cannula, meaning there was a suture problem, it's the surgeon's fault.
Well,
Gross.
I know.